time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Big game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the truth. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go. Yeah, I got.
Good day and welcome to Kidney Hub East Africa. Today, we are bringing you an important conversation on dialysis in Kenya. Challenges, gaps, and solutions from a nurse's perspective. Now, we got two nurses on here. We got our special guest, Nurse Rose, new to the show. And we have our co-host, Nurse Tabitha Matekwa, renal nurse specialist, all the way from Nairobi, Kenya. You're not going to get no show like this across social media focusing on kidney disease education, promotion, and advocacy. Now today, let me share with you, dialysis remains a life-saving treatment for many people living with kidney failure. But in Kenya, patients and families, let me not just say Kenya, let me say East Africa, because that's the name of the show, Kidney Hub East Africa. But specifically in Kenya, patients and families continue to face major challenges, including access, affordability, and quality of care. Now, to help us unpack this topic, we are joined by a powerful team. Our co-host, Moses Kennedy, popularly known as the Kidney Ambassador, and renal nurse specialist, Tabitha Matekwa. And together, they will guide us through this conversation and help us understand the realities of dialysis care in Kenya. Share this live, seriously, especially if you're watching from East Africa. Get this broadcast out. If you are a professional in East Africa, nurse, kidney doctor, dietitian, social worker. Share this live with your patients, even the rebroadcast, so we can make a difference, not just in East Africa, but in Kenya. So today, we are also honored to be joined by a special guest, Rose Gitau, RN, a Kenyan nephrology nurse, kidney health advocate, and community health champion. Now check this out, who brings decades of experience in renal care. And I'm sure kidney warriors in Kenya need nurses like Rose. Need nurses like Rose and Nurse Tabitha. So welcome everyone to Kidney Hub East Africa, where we are glad to have you with us today. Now we are broadcasting live on Steve the Kidney Nurse YouTube channel, Facebook page, and the FIGO Initiative Facebook page. So please feel free to share this live broadcast with your family and friends. So sit back, stay tuned, and let's learn, share, and grow together on Kidney Hub East Africa. Now, before we bring out our co-hosts and guests, let me go over our medical disclaimer, because we don't claim to be any doctors. We're nurses. I'm a nurse in the U.S., and we have two nurses from Kenya. Brother Moses is an advocate and also a kidney warrior who's been on dialysis for about 10 years. Let me find my overlay. Here we go. On Kidney Hub East Africa, the information that's broadcast on Kidney Hub East Africa is provided for educational and informational purposes only, and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Now, with that being said, let me bring on our co-hosts and give them the VIP welcome all the way from Nairobi, Kenya, the kidney ambassador and renal nurse specialist, Tabitha Matekwa. Let's give them the VIP welcome. Brother Moses, Tabitha, how are you? Let me switch you over. There we go.
Hey.
How you doing, Sister Tabitha? How's everything?
Hey, I'm fine, thank you.
Good.
Yeah.
Brother Moses, what's going on?
Yeah, so great here.
Uh-huh.
So great.
So-
Though we are running blackout in part of the country. So I don't know that is what affecting Tabitha over there.
So you're saying you're experiencing a blackout?
Yeah.
Me,
How
I
long does
think
that
it's
normally last?
Oh, okay. Sorry?
I say, how long does that normally last?
No, you can't predict.
Okay.
Yeah.
So let's bring on our guest. But before I do, let me read this impressive bio. And Tabitha, Nurse Rose said before the show that you was a mentor to her, and you know she really respect and appreciate you. So, I mean, it seems like, I'm not over there in Kenya, but it seems like it's when it comes to the professionals in the renal community, meaning the nurses, that it's a close-knit community, and that it seems like the last two nurses that we had on here know you and highly respect you and your professionalism. So I mean, that's really good to know and to see that you're making an impact when it comes to kidney care. But let me read Nurse Rose's impressive background. Rose Gitau, RN, is a Kenyan nephrology nurse, kidney health advocate, and community health champion, passionate about preventing kidney disease through early detection, health education, and community empowerment. With over a decade of experience in renal care, Rose has evolved from working at the point of kidney failure to championing prevention upstream. She is the founder of Figo Na Afya. I hope I pronounced that right. Machina. I hope I pronounced that right. By now, please correct me, Brother Moses or Tabitha. And the Renal Ready initiative, through which she equips communities and frontline healthcare workers with practical knowledge to recognize kidney health risk early. Her work brings together kidney health, community health, NCD prevention, maternity and child health, and healthcare worker capacity building. Rose is passionate about changing the narrative from waiting for kidney failure to preventing kidney disease. Now, Tabitha, when you hear that, knowing that you may have had some part in training roles or however it is over there in Kenya when it comes to kidney disease education and nursing, what comes to you when you hear that from someone who came through your, I don't want to say ranks, but that you had dealings with as a kidney nurse?
I feel so good. I'm so happy to see what Rose is doing at the community level. She is busy educating even community health workers. She's there teaching in the church, making a very great impact even to the young nurses, and it makes me feel so nice. Meaning, we are going somewhere. There's an impact that is being made. This advocacy is working. Mm-hmm. Thank you.
So, when you first met her, did you expect to see this from her? The work that she's doing and what she displayed in her bio? Did you imagine her turning out to do this when she first possibly started dialysis?
I think when we first met, I didn't see all this potential, and I'm glad this girl has great potential. She's really already making a very huge impact. She's bigger than you can see. Yeah.
Okay. Hey, put me on, Rose, Nurse Rose. But no, Brother Moses, let me ask you before we bring on Nurse Rose. You as a dialysis patient, you've been doing this almost a decade yourself. Have you ever came across the care of Nurse Rose? Has she ever provided services directly to you as your renal nurse?
No. We haven't met. But I know her through a friend that linked me up to her. So we haven't met. so far. Yeah.
Okay. So let's welcome our special guest, Nurse Rose Gitau, and I hope I'm pronouncing the name correct. If I'm not, please correct me, Rose, when you come on. But let's give her the VIP intro. Nurse Rose, welcome to the show. How are you?
I'm fine. That's a very powerful intro. I almost danced to the tune, you know.
Thank you so much for coming. What does it mean for you to be here today, especially doing what you do in Kenya?
Okay, for me, this is a dream come true. It is a tick in my box of things that I needed to do. You know, when I first saw the Steve the Kidney Nurse, that I think was one of the earliest podcasts of videos you did, and the guest you had probably had a lot of network connectivity issues, so I was trying to follow through and I didn't manage. So since then, I did not go back to watch what happens, but I've been seeing the flyers, and yes, I've been looking forward to this. And of course, having to meet Miss Tabitha again, sharing one platform with her, I feel home. I don't feel like I'm in a place where I'm not home. I feel home. I feel like my big sister is on board. So yeah, I'm at my safe space.
Thank you for sharing that, because that means a lot to me. And Brother Moses will share with you. You know, mentally, sometimes I think because we have a low turnout on our shows that we're not making an impact. And to hear comments such as yours and not knowing, you know, what goes on in Kenya on an everyday basis, it's kind of just refreshing to hear that. So thank you, you know, for those comments, because I don't know who's watching in Kenya. In fact, I honestly just looked at my page today, the dashboard, and a lot of my support is from Kenya. So I was going to share that with Brother Moses, but again, thank you for that. And just like Tabitha, you are more than welcome, please, to come back and share any topic that you feel can get out there that's important, that you may share or advocate for, or you want to talk about. You more than welcome to come to me, Tabitha, Moses, whoever, and say, you know, y'all want to do this or do that. We have no problem. So I just wanted you to know that. So let me begin with this, Nurse Rose, because our topic is dialysis in Kenya, challenges, gaps, and solutions. Now, from your perspective, what are the biggest dialysis care challenges you are seeing in Kenya right now from a nephrology nurse point of view?
Okay. So personally, I am not working in the dialysis unit setup. However, I can be able to relate the same challenges that I used to see when I was hands-on working in a dialysis setup. I believe that things have not actually changed, because the demands of dialysis remain to be the same, that a patient is required to be in the renal unit at least twice a week. So what implications are we talking about? This person has to be off duty for 2 days in a week, or if they're self-employed, it means they have to close up their business for 2 days in a week. So that is a financial implication on the side of the patient. Number two, the caregivers who have to, one, they need to foot the bill for the transport for this patient to be able to get to the facility and in time. Number two, they also have to ensure that the patient is able to get the correct diet for their care. So that is a financial implication on the side of the caregiver. Again, the other thing is that in the community, this patient is required to serve different roles. Supposing they are the only people with a cyber cafe in their village, and for the 2 days in a week, they have to close down their cyber cafe. So that means all the villagers will be stranded for the 2 days that this patient is in or is out for dialysis. And also, even if they were supposed to be offering a service in a certain office, so when they are not there, it means that all the clients will have to be moved to another day or to be rescheduled. So that means that this roller coaster also extends to the community, because these people have different roles. Also, the government, nowadays, that the social health insurance fund is able to cater for the dialysis treatment. And for the sake of the viewers who may not be familiar with the exact price for dialysis, especially if you're watching from Kenya, for one dialysis treatment, you spend around 12 to 13,000, and your patient requires around 2 or 3 sessions. So you can imagine how much is that per week, how much is that per month, how much is that per year. So 10 years ago, when I used to be working in a renal unit, but then the government had not chipped in to pay for these patients. So it means that patients could only come to the dialysis unit when they could afford care. It was not about who needs care or it's their right to get care, but since they were paying out of pocket, it was a question of, have you raised the 10,000 Kenya shillings or the 12,000 Kenya shillings that is required? And the answer is, if it's no, it means you'll have to miss your sessions until when you can be able to afford that care. So now that same burden has been shifted to the government, considering that the patients used to have 10 years ago have either, I don't know whether to call double, triple, or it's just crazy. The number of patients used to have 10 years ago and the number of patients we are seeing now. So that means that the burden is way higher on the government. The money that is supposed to be building schools and roads and electricity is now used to cater for an illness that the government has no obligation but to cater for the sake of the patients who are on dialysis. So we always say that a healthy nation is a wealthy nation. So that means that these people who are supposed to be productive citizens, contributing very well to the economy, now they are stuck. They cannot be able to do as much as they used to, because it is also physically draining, the dialysis process in itself. We have our brother Moses on board. He can be able to tell us that sometimes what he was in a capacity to do maybe 10 years ago or before dialysis, probably by now he's not in a position to do that, because sometimes the dialysis, it drains your body physically, your physical strength, it goes eroding, as we will be discussing further in the conversation. So yes, those are some of the challenges, I'd say, listing it from the individual to the family to the community to the government. Yeah, those are the challenges.
Tabitha, let me ask you, because you work at the hospital and I know you work with patients. What are some of the biggest challenges, some of the biggest dialysis care challenges you are seeing in Kenya from your perspective?
We have the issue of finances. Where as much as our hospital insurance fund can pay for dialysis, if a patient has an issue with the catheter, tunnel catheter is paid once a year by the insurance. Apart from that, if it's a temporary catheter, they have to dig deeper into their pocket. Again, if a patient has to dialyze more than twice, the third session they have to do it from the pocket. For the family, it's also very much draining, just like the way Nurse Rose has said, and of course to the country, the same challenges. We also have issues with consumable. If let's say if there's delay in procuring the item, that delay might mean might cause a challenge to our patient because of maybe issue to do with the tender or even to do with the finances, depending on the institution. So the challenges are quite many. Patients also sometimes they are not able to adhere to the diet that has actually been prescribed, and mostly you will find it goes down to the finance issue. And again, also most of our patients, sometimes they lack support from the family. If you dialyze for a long time, many other people withdraw, and when that support is not there, it means our patient may not do very well. Yeah. Thank you.
Oh, I'm sorry, I had my mic muted. Tabitha, the next question is from you for Nurse Rose.
Okay, thank you very much, Brother Steve. So, Nurse Rose, for many families, hearing that a loved one needs dialysis is very overwhelming. What's usually supposed to be the first advice to the patient and to the caregiver when they see news dialysis?
Nurse Rose, can you hear me?
Yes, I can hear you, but I didn't get the question from Tabitha.
So, I'm going to repeat the question because Tabitha's having internet problems. Her question was, for many families, hearing that a loved one needs dialysis is overwhelming. What is usually the first thing you advise patients and caregivers to do when they receive that news?
Wow, thank you for that question. At some point, there is a platform called the Renal Patient Society WhatsApp group in Kenya, where the kidney patients and their caregivers are joined together in one platform. I am a nurse. I'm a nurse in that platform. I'm there as a nurse in that platform. And for the 10 years I've been in that platform, I sometimes just throw some questions, some polls on that question, just to see different perspective from the patient's perspective on different things. So there is a time in 2024 I had run that question to the patients so that I can be able to get their perspective. And the question I asked them was, how many minutes did the doctor who told you you have kidney failure take to just share with you, to break the news to you that you have kidney failure and you need dialysis? So how many minutes did you spend in that doctor's room for you to get such news? I'd say that over 80% of the patients, they spent less than 5 minutes in that doctor's room receiving that kind of shocking result, information. Like the doctor only said that you have kidney failure and you're supposed to go and get your catheter done and you need dialysis in the next 2 hours. Actually, you need to be on dialysis. So there are those patients who received that information very fast, no preparation. They were just overwhelmed. And then we also have a list of other patients who went through a process of the doctor having to prepare them for some time. Maybe they were managing them for the diabetes or from the high blood pressure, and they were running some kidney function tests in the background. And they were able to see that maybe in the next 9 months, you may require dialysis. Then they start preparing their dialysis access. And by the time they are now told they need dialysis, these are patients who even get to meet someone like Madam Tabitha before they get to their first dialysis. The patient and the family, they are taken through renal counseling. They are taught exactly what to expect. They have time to ask all the questions. But again, then there is another third category of patients who only closed their eyes and opened their eyes, and they found themselves lying beside a dialysis machine, which was actually hooked to their body. And these are the patients who probably were walking with blood pressures of over 200. And then one day they just collapsed at the market, and then they went straight to ICU. And the next thing, they were already on dialysis, and then they've never left that space ever since. So my research has brought me to those different. Yes, please.
No, I'm sorry to interrupt you. Let me ask you: is there emphasis put on prevention?
Wow. Emphasis.
Yeah, I mean, like if someone, like you mentioned that someone 9 months, that's a long time, but you mentioned what to expect, but I didn't hear anything you shared of trying to stop the progression of kidney disease or knowing, because we know, at least here in the United States, they have the stages, go by 5 stages. And so is there any emphasis there when it comes to when someone gets diagnosed with, say they in stage 2, do they try to prevent that from progressing, or they just let it kind of play out to it get to stage 5 and they go on dialysis?
Wow, that's a very, very good question. And I sit at the intersection of having practiced as a general nurse. I also practiced as a nephrology nurse, but stationed at a health center that is working at a rural place. So I have interacted with the challenges that we have in the lower levels of the healthcare system, whereby you can see the patients who are on stage 1 or stage 2 of diabetes, and they are living in the rural communities. These are patients who have never had anyone talk to them about kidney disease. These are patients who are actually in denial of the hypertension and the diabetes in itself. These are patients who even have no access to kidney function checks. These are patients who do not even know the importance of it. Again, worst of it all, these are patients who are in the hands of frontline healthcare professionals who actually, not to blame them, but frontline healthcare professionals who are not empowered enough to help patients to delay the progression of chronic kidney disease, because the curriculum we have at the general level, it only discusses the anatomy of the kidneys and the basic physiology, but no one teaches these frontline healthcare professionals on how they can be able to join the dots, on how this patient in stage 1 or stage 2 of kidney disease, who is coming to them on a daily basis, how is their role, how are they supposed to help this patient to delay from getting to those stages which will require dialysis or kidney transplant. For the sake of the viewer who has just joined in and may not know, let me say in a nutshell that kidney disease is just like cancer, whereby we have cancer. Everyone knows that cancer comes in stages, stage 1, 2, 3, 4. It is the same as kidney disease, where we go all the way up to stage 5. So let them not feel confused when we are talking about stage 1 or stage 2 or stage 3. And also to bring them to the light is just to tell them that as long as a patient has long-standing diabetes and hypertension, it means that this patient, their kidney function is already getting compromised by day. And these are the high-risk patients for getting chronic kidney failure. And these are the patients who we are talking about that needs to be salvaged very fast. They are these patients we need to give much support in terms of their, one, they need to accept that indeed they have high blood pressure and the diabetes so that we can contain it at that level. 2, they need to be on the right diet and they need to be referred to the nutrition. And also they need to be taught on the need of compliance for the sake of preventing complications, to include chronic kidney disease. These are the patients who are living in the communities where here in Kenya, some parts of Kenya, they really embrace the under-researched herbal treatments. And these are the same patients who are the top candidates of using the herbal treatment. Sometimes they are the same patients who are exposed to over-the-counter painkillers because probably they have diabetes, hypertension, and maybe an arthritis is knocking here and there. Or also because they are probably not taking, are also getting those frequent headaches and pains here and there, or even the early signs of kidney disease are catching up with them, but they don't know that they are supposed to be proactive on their own health. They are supposed to go to the health center and even request to have their urine done, the basic test, because no one has empowered these patients. So that's how my work comes in. My work comes in as one who has seen the patient's agony, have seen the family suffering, have seen how the much resources we are using into it. And now I decided to work in 2 dimensions. One, because I realized that the masses are losing it because of the masses are getting there out of the ignorance of the simple things they ought to have been told by someone, for which we were not able to reach them in time, and that's how they got in the renal unit. So my mission entails going out and reaching out to people wherever they are, be it in the offices, be it in the churches, as Tabitha was saying, wherever they are. Even today was it a family event, but I still use that platform as a platform to educate the people on the need to safeguard their kidney health, because I don't want them to come looking for me as they are keen to help them maneuver the lines into which to get the dialysis care, I want them to make the best of my knowledge by understanding the basic prevention. Number two, I also realized that gap of knowledge, we need to bridge the gap between the classroom application of kidney health concepts to the clinical application of kidney health concepts. That nurse who is working at the health center alone at a dispensary near the bush, they need to know how that mother who is coming in for delivery, how are they supposed to handle that patient to ensure that this baby and this mother come out without getting complications that put them at risk of kidney disease. That clinician who is working in wherever, the most rural part of this country, need to know that the choice of medication they choose for these patients who are at high risk of kidney disease, are they having those special considerations for this? Because I realized that they are innocent because no one has taught them, but the errors of omission and commission and giving misinformation to these patients actually lead to poor renal outcomes. I interact with these patients at the Renal Society platform, and sometimes they are cursing frontline healthcare workers who were the first people to handle them, because sometimes they get those high blood pressures, and then they were told, just go home, your BP is fine, it's supposed to resolve it itself, so that's why I'm coming out strong, because I realized that much as I was engaging much in doing the awareness for the public, I couldn't do this alone. That's why I need an army of empowered frontline healthcare workers. And how best do I reach out to them? The best way to healthcare workers is by writing books. So I have written my first book. It's called The Renal Ready Workforce. So I am intending to run an international book tour whereby I want to reach out to the healthcare professionals right from the universities, whereby they can be able to understand the simple procedures that they do at the hospital, that they go a long way in leading to either good or poor renal outcomes, and to just shift the power and the glory of nephrology to the frontline healthcare professionals. Because sometimes we think that the nephrologists, all the nephrology nurses are the heroes, but for me, in my evaluation, the frontline healthcare professionals are actually the real superheroes when it comes to kidney health, because they interact with the patients long before their kidneys have a problem. So I'm running those two things concurrently, reaching out to the masses, and through my initiative called Figo na Afya Mashinani, for which I have a team where we are now embarking on a county-to-county project, whereby we are going to do screening projects in the communities, training community health promoters. We actually did a pilot project within Matekwa, where I am based, but now we want to extend the same to Kakamega, Kisumu, and Mombasa counties, and also Kiambu, Kakamega, Kiambu, and Mombasa County, so that we can extend the impact of Figo na Afya Mashinani beyond Machakos town. But for the Renal Ready campaign, I call it an international book tour, because even with my interaction from the LinkedIn community, frontline doctors are coming out, nephrologists are coming out to say that these challenges are not unique in Kenya or in Africa alone. They also need the energy and the concept behind the Renal Ready to their system. So that's what I could say.
Thank you. Thank you so much, Rose, for such a deep expansion. And I love the way I saw you one time teaching the community health promoter, and that sensitization. Community health promoters are the people who are on the ground with the patient. These are the people who go around checking on the blood pressure from family to family in the community. And when they are able now to learn what the impact of high blood pressure on the patient or unmanaged diabetes, it is going to bring a lot of value, because now we'll be able now even to get many people being diagnosed early, and the prevention measures can be applied very early. And I just love now what you are doing as a renal nurse. I can hand over maybe to you, Brother Moses.
Thank you so much. Thank you so much, Tabitha. Nurse Rose. I have some few questions. Let me begin by this.
Okay.
Yeah, for many families, what are some of the main gaps in dialysis care in Kenya that affect patient the most? Is it the access or cost or something else? Yes.
Okay. One, I'd say with regards to access, there's been a lot of energy, or we can see the private sectors and the government. The time I was working in the dialysis space, the county governments were just starting to set up the dialysis centers across the counties. But now I think each and every county has a government dialysis center, and also the private investors have really put in a lot of emphasis on starting up dialysis units. But all in all, the numbers of patients who need dialysis are rising even the more. So you'll still find the waiting days crowded. You'll still see patients having to wake up at 4 a.m. to be able to access dialysis care. And in case there is a breakdown of one or two machines, then that becomes a nightmare for that patient. And it affects it cuts across all the shifts that were supposed to be done for that day, meaning that at some point patients will have to sleep at the benches overnight so that they can access the machine the following morning. So it's a plus for what they have been. It's a plus in terms of the number of dialysis centers we are seeing now. However, it is still not sufficient to serve the kind of numbers that we are having in terms of the kidney patients. And I don't think it will ever be enough until the time when in my prayer, or rather in my biggest wish, would be nephrology nurses. And Kenya is blessed to be part of the East Africa Center of Excellence, because that's an institution that has been able to move Kenyans from a handful number of nephrology nurses to hundreds of nephrology nurses because of that training. So in Kenya, we wouldn't say that we have very few nephrology nurses. We have them. However, our scope of practice demands that once we specialize, we're supposed to be working in the dialysis unit. Like the system equates renal nursing is equals to dialysis services. We forget that in the same class we learned renal nursing, we were also taught the preventive. So we go into the dialysis units with the preventive concepts very fresh in our minds, but to the wrong audience, who are patients who are already on end-stage kidney failure. But again, the system, the dialysis units are so overwhelming that nurses go in there, they have to pull over the shift. They don't even have time for the advocacy, as much as they would love to step out there and maybe do what I'm doing. Personally, I really struggle to juggle in between my routine job, because I am supposed to be working in a dialysis unit, just that I made a choice and a request, a very official request to my employer, just to have me outside the renal unit. I would like to other counties to embrace what Machakos County has done with me, to just have me as a nephrology nurse, yes, but they have not pushed me or gun-pointed me to tell me that you must be working in a dialysis unit. So probably I just do my shifts in the unit where I work. That's a newborn unit. And then when I'm on my day offs, that's when I sit to write my Manila papers. That's when I sit to strategize. That's when I just do all these things that you see out there. It's just a product of the quiet work that I have to sit down and do. That's a lot of sacrifice, juggling in between personal life, my work, and also now the advocacy that I have to do. And I just decided to do it until when I can put out the results of my work out here for someone to just ask, when do you do this? And that's when I'm hoping that the Nursing Council of Kenya can be able to just say that nephrology nurses, a section of them, should not be stationed in any other place. They should just be stationed to do kidney health advocacy. Either they are doing it at the community or they are doing it in the other units, supporting the other frontline healthcare workers. That is the day we are going to have less numbers or less people knocking in the dialysis unit. Otherwise, as it is now, we are just going to continue in the vicious cycle of welcoming new patients every day. And remember, once we welcome them into the renal unit, it is not like the child immunization, where the child will just get their scheduled immunization, they are done, and they don't need the child welfare clinic again. For the dialysis, once you're in to stay. So we need to close that door by doing those interventions that I am speaking about. And this would be my happiest day in my profession. Just seeing that I'm waking up to do advocacy and I earn my salary just for that, or for that, not just for that, but for that, that would be my happiest day.
Wow.
Oh, wow.
So that's great, Rose. What is the ratio? Because you've mentioned that we have enough nephrology nurses. Do you only have doctor ratio to patient ratio gap so big, or what is the ratio of nurses to nephrology nurses versus patient?
Oh, the ratios are not impressive at all. The ratios are not impressive at all, because a patient on dialysis is actually like a patient on a critical care, is a patient who is on critical care. So this is a nurse in a renal unit or in a dialysis setup. They should only be focusing on maybe 2 patients at a time. But sometimes you just walk into a dialysis unit where one nurse is actually running across 10 patients. So for which one, for those patients, for those viewers who are watching for the first time and are not familiar with dialysis, well, the dialysis treatment, the 4-hour treatment is like a life and death situation for that patient. And each session is not the same as the previous session. Emergencies do occur within the course of the dialysis. Patients, sometimes they go on low blood sugar, others the blood is spilling here and there, others are vomiting, others their blood pressure is, others are even convulsing, and this nurse is supposed to attend to all these patients. So it is usually very chaotic, and sometimes it becomes, it gives the nurses no job satisfaction at all, when they feel they needed to do better, but they were the ratios were not even there. they were not even pleasing, the ratios. They have to attend to all at once. And something else I'd like to mention, which is very, very important, is the nurse and the patient. They don't have time to talk. They don't have time to talk beyond just having a patient, telling the patient, remove your shoes, step on the weighing scale, go to your bed, let's do this, let's do that. After 4 hours, they clear and they're out. This patient only feels comfortable around their dialysis nurse because this is the nurse they see each and every time. Sometimes they want to share issues, but sometimes the nurse may not have the time even to attend to their needs. So we need even more and more nephrology nurses to be trained so that we can have, even within the renal unit, we are having a nurse who is on duty, a dialysis nurse who is on duty, and their work for the shift that day is not to hook patients and to unhook them. It's just to speak to the patient, bed to bed, talking to the patient, listening to their concerns, because we are having even suicidal cases among our dialysis patients. Why? Because the psychosocial stressors in the care, in the dialysis in itself, they just are enough stress beyond even the kidney disease in itself. So we need more nurses, because that is when we can be able to have very efficient services, because we talk about primary prevention, secondary prevention, and tertiary prevention of kidney disease. The primary and the secondary are for those who are not on kidney failure. But for the patients on kidney failure, the tertiary prevention involves having a good quality of life for this patient, despite of them being on dialysis. You want to look at this patient holistically. You want to address, in our curriculum, there is something we used to call the Gordon's pattern of history taking. A renal nurse should even know where the patient goes to church. They need to know what is that one thing, if I tell this patient, they will brighten up. You already know what makes them happy. You already know if they are involved in a sport. You already know who came to visit them when. We are supposed to go beyond when we have one, less patients coming in to join the caravan. Two, when we have more nephrology nurses in the system, because even if we were to bring clinical counselors, they would not fit in the renal unit per se, because it takes a nephrology nurse who has more knowledge or who has time to talk to this patient, to actually talk to the patient in a way that the patient can relate with. You just don't get any other counselor to speak to a dialysis patient. They will not fit in.
So from right there, let me cut in, Nurse Rose, and ask you this question. It kind of fits right in with it. So from your experience, can you briefly tell us, how can nurses help patients prepare emotionally and physically before they start dialysis?
You mean general nurses?
Any nurse that comes in contact with a patient that's about to start dialysis, whether it's a general nurse, a renal nurse, or maybe Nurse Tabitha could weigh in. But from your experience and working with renal patients, how can renal nurses help patients prepare emotionally and physically before they start dialysis?
Okay, I'd just say, in a perfect world, this should happen. Personally, I just felt like beyond what I've been practicing over the years, I need to add into my skill set the real act of psychological first aid, because this is like a trauma that hits. This is some bad news that has hit this patient or the family. No one prepared them. It just came. Those are the news. And now, how do you take them? How do you take them through this? I have all along been counseling patients. I have all along been talking to families, even once they are not yet on dialysis. You talk to them when they are at the stage of diabetes and high blood pressure. You want to teach them on the likely complications so that they can take it seriously at that level. But again, when we hit that level, you want to teach them that this is actually not the end of life. What we do is we link these patients to other champions or other warriors who have been on the journey. Like, I'd be very comfortable linking a new patient to our brother Moses here, because much as I could be able to share from my perspective as a nurse, the patient can easily dismiss my advice and say, you are only saying that because you're not the one sitting on this side of the table. So peer support is one thing that really comes in handy, because the patient is able to learn from a warrior who is actually on dialysis, has been on dialysis, is able to continue with their life goals, is able to, those patients with positive stories, they have even been able to undergo university despite being on dialysis. You get to walk them through that journey. And there is that way we do to link them and also to teach them and the do's and the don'ts, and also just taking them through, and also allowing them to ask questions, because from there you can be able to see how to come in. And also, it's now we are in a world of technology where patients and family, you just tell them their diagnosis, and the next thing they are on the AI apps trying to Google and search what exactly that means. And I have some bad news with that. I really am a lover of AI, and I really embrace technology and new knowledge from the internet. However, with kidney failure, I really raised some very serious alerts, because with kidney failure, the internet can be very misleading. Maybe you can read about other things, but with kidney failure, the internet can mislead you big time. One simple misinformation from the internet with kidney disease, you could land to the ICU the next minute. Why? You could just read something like as simple as a banana. The AI app, based on the prompt that you have been able to give, you can give a wrong prompt, and then it can tell you that bananas and avocados are actually very good fruits. You need to have them on your diet. So as a kidney patient, if you just trust the internet, you don't want to open up to your healthcare, to your dialysis nurse, then you will end up being the next patient landing in the casualty just a few minutes after you left dialysis. So AI technology is good, but when it comes to kidney disease, that's where we draw a line, and a red line for that matter. So draw the support from all other places, but the internet may not be your best friend. Also, with peer support, one thing I've come to learn from my experience in the renal group, sometimes 1 month's meat is another month's poison. We have some fruits, probably. I'll give an example with some fruits like the pineapple. You realize that some kidney patients, they comfortably take pineapple. But some other patients, the same patients on dialysis, when they take even a slice of pineapple, they have problems. Another one can comfortably eat an egg, including the yellow part of the egg. Yet the other patient on the next dialysis couch, if they eat that egg as it is, now it starts becoming a problem. So again, 1 month's meat is another month's poison. And there is a slogan that I usually emphasize on at that platform. I call it, for the ones who are understanding Swahili, I call it Jijue Jipange. Jijue no jipange. Like, you need to understand what works for you. What did the doctor say that works exactly and precisely for you and your kidney function test results, and not borrowing a leaf from each and every other person. So the patient support networks are very good, but also they need to be taken also with a pinch of salt. There are some things that you don't apply directly to yourself. So for me, what I'm doing in line with upscaling my skills, I have enrolled in a program where I'm learning trauma counseling and psychosocial support, so that I can be able to incorporate my nephrology nursing background with the counseling, with the correct counseling skills, because I really don't want to work from a space of assumption. I really need to upscale and do it even better than what I've been doing.
Mm-hmm. Okay. Tabitha, it's on you.
Thank you so much, Nurse Rose, even for that, and even having an interest in trauma counseling and psychosocial support. It's going to add a lot of value to our patient, and even as we prepare our patient emotionally and physically, I start with telling them the function of the kidney, the way it's able to remove the waste, excess fluid. Again, also the function of the kidney towards the bones, and even the maturation of the red blood cells. And now when the kidney is not working well, what happens to the body? Then after explaining to them the function of the kidney, I help them interpret the lab results, the urea, and the creatinine and the potassium. What are the normal values? I tell them these are the normal values, and now your creatinine today is 1,000, and the normal is supposed to be this. Now today your urea is this much, and it's supposed to be like this. Your potassium is this value, and what is the implication when the creatinine are this high, when the potassium is this high, and even when the urea is this high. I let them understand. Then I explain to them what happens even if they are not feeling anything bad, because mostly a patient is supposed to start dialysis, they don't even have to be feeling anything bad, but some of them might be experiencing maybe only fatigue, unexplained fatigue, but when we check on the lab work, they are really bad. Then I tell them the doctor has recommended you need to start dialysis. And what is dialysis? Explain to them. I explain to them how a catheter is inserted and where it is inserted if they don't have fistula. If we had time with them, maybe they would have created a fistula earlier before. But if they don't have, I explain to them about the process of catheter insertion, and then again also how to take care of the catheter, and again also the infection prevention. And now when they start dialysis, we start with the 3 sessions, then we stabilize with 2 sessions, and why they need to adhere to the dialysis, and I prepare them together with the relative if it is possible. And if they start dialysis before maybe I can talk to them, I will explain to them maybe later when the levels of the urea and the creatinine are not very high. So maybe to ask you, Nurse Rose, how do issues like treatment, like transport, treatment costs, and repeated hospital visits affect the daily lives of the dialysis patients and even their family? How?
Okay, I'd go back again to giving credit to the experience that I've gained as part of the Renal Patient Society of Kenya. That platform has really, really helped me to be able to view the experiences of patients and families, even from the point of not commenting, but just reading out what they are able to share. I'd say that one, these patients, do you know that they even do some mini fund drives among themselves? Because you just see a patient just typing there and say, I'm actually a kidney transplant recipient and I have run out of medication. And for the sake of the audience who are not familiar with what I'm saying, for a person whose kidney function has failed or a person with kidney failure, number one, either they are on dialysis, or number two, it is either another healthy person with two kidneys who is supposed to have one of their kidneys removed and put inside the body of this patient with kidney failure, so that this patient now can stop dialysis and continue with their normal life. That is what we are talking about, kidney transplant and recipients and all this. However, when you get your cousin giving you their healthy kidney, the journey does not end there. It actually begins there, because there are some drugs that you're supposed to take each and every day so that your body, because when God created you, He created you as an individual. He did not create you with your cousin's kidney inside of you. So what are you going to do so that your body does not sense that there is a cousin's kidney inside of you? That's why you have to take a whole packet of pills on a daily basis, and on a mandatory basis, you have to take each and every day several tablets, which are not cheap tablets, so that your body does not shout, there is a foreigner in this body. So those are the medications we are talking about. And if that patient does not take those medicines, that new kidney will start misbehaving, if I can use that word. That new kidney will start misbehaving, and your own immunity will fight that kidney. And then you will become very sick, and you'll need to go back either for admission and even for dialysis again. And then you start the cycle of raising funds to get another donor and to get another kidney from another person. So that's what we are talking about, how desperate these patients are to ensure that they get this care, which may include this medication. So these patients, they actually do some fundraising amongst themselves. So for a patient to start doing fundraising with fellow patients, what does that tell you about their support system back at home, back in their village, back in wherever? You know, sometimes, because I have sat around communities, I have been working in a village setup for the last 7 years. So I know what the community members speak about these patients with kidney disease. They say that this family is really taking advantage of us. They think that now this illness has become a source of income for the family. Why are they always asking us for money each and every other time? Why are they always talking in church, giving their sad stories, and they want people to raise money? Didn't we raise another 40,000 for them last year? What did they do even with that money? We didn't see this patient move from point A to point B. What are they actually doing with the money? So just to emphasize and to clear the air for these families and these patients, is that once a patient is on kidney issues, the issues keep coming. Sometimes they need admission. Sometimes, as Madam Tabitha was saying, their dialysis catheter, which is like a plastic thing like this pen here, that stays inside. It stays inside their clothes, and they stay like that, and they come to your weddings and they go to school and they go wherever with that plastic thing inside. But then when they go for treatment, this plastic thing is exposed, and then the tubes are hooked here, and then blood moves out of their body, and another tube takes blood back in their body. And then after the 4 hours, it is covered very nicely. So if they are members of parliament, they go back to parliament with their suits, and you will not notice a thing. So sometimes this thing, it fails. So when you go for the dialysis procedure, the nurses, they try to pull blood from here, they try to have the machine running, but it cannot run. So it means this patient needs to have this thing removed. They are taken back to theater and have another thing that is inserted here. And that is what we are saying. Our social health insurance fund may cater for dialysis, but it will not cater for that thing to be put there. And that thing for the Kenyans in the house, sometimes it is as expensive as 50,000, 40,000, and that patient requires that. That is their lifeline. Without that thing there, that patient, there is no way we can be able to help them in the dialysis unit. So the costs are there. That's why these patients keep asking for money, because also even their diet is also very special. And yeah, much as we try to encourage them to eat what is available, sometimes what is available messes them up. So the costs are just a roller coaster of bad things. And that's why my slogan is always, prevention is better than cure.
Thank you. Thank you so much, Nurse Rose. Brother Moses.
Yes, thank you so much, Tabitha, for that query. My good sister Rose, in your work, what role do frontline healthcare workers play identifying kidney disease early before it reaches the stages of dialysis? I hope you are unable to see me because we are running on a blackout. So please just bear with me, everyone. Yeah.
Yes. Well, that's a very good question. That's the kind of question I need now more than ever. And for the
I know that is where your
workers,
strength lies.
Yes. And for the frontline healthcare workers in the building today and tonight for this meeting, and also for those who will watch the rerun, if I was having a medal right now, I would actually give you that medal even before I answer this question. Just like people go to a wedding and they get a ring and they get a marriage certificate even before they get into the marriage. That is what I would do to them right now. And if I knew the emoji that can actually give me that, I'd actually give them their flowers and their medals right away. Why? And I would not give Tabitha because she's a nephrology nurse. I'd give those ones. I'd give that nurse who is working at a space where at a place where it floods and they cannot move from point A to point B. That person is the real hero. So what do they do, or what should they do? I feel with the support of us in the nephrology space, they should be able to relate their each and every day procedures. Because if I was to come again in another session, I would be able to explain exactly how each and every part of the population is affected by kidney disease, including the newborn baby who is born today, the 16th, and by the 19th, they actually need dialysis. And between the 16th and the 19th of August, this baby or this newborn baby was in the hands of a nurse who is not a kidney specialist. But while they were on their hands, 3 days later, they need dialysis. I usually tell people that newborns undergo dialysis and they make that kind of a face because, newborns, they need dialysis at some point. The old people, They also find themselves a pregnant mother who walks into the antenatal clinic. Maybe just to unpack that a little bit. This newborn unit who is born to a mother, this mother is not able to breastfeed the baby for the first 24 hours of life. They cannot make any milk. This mother is probably in a health center somewhere, in a health center or in a dispensary. The facility is closed by 5 p.m. So if that mother delivered at 10 a.m., by 5 p.m. they are actually discharged and they have been sent back to the village. As long as they are not having postpartum bleeding, that is just enough for the mother to be discharged. However, you didn't even have time to see whether this mother has a support system at home. You did not go ahead even to check whether the nipples of this mother are inverted, or what is the likelihood of that this mother is actually to breastfeed this baby very well within the first 24 hours. You didn't have all that. You didn't even know that actually that is important. So you just discharge the mother, and maybe you don't make any follow-up. So what happens to that newborn baby? They just go back at home. And then the mother, of course, even when you call her and ask her, hey, how are you? Congratulations on your bundle of joy. Have you breastfed the baby? That mother will tell you, oh, my breasts, actually, I'm only having some powder coming from my breast. I don't have any breast milk. And then they'll just say, it will come. You just chill. It's just going to come. Just eat ugali. And then the following day is on the 17th. The milk is just coming in, just a bit, scanty. And then by the third day, that newborn already has a fever. That newborn is already a bit lethargic. That baby, the fontanelle is almost dry and it's getting sunken. The baby is less responsive. And also the baby is not passing urine. Every 3 hours, the mother wants to change the diaper. The diaper is still very dry. Did the nurse at the health center teach that mother the danger signs to watch out on in case you see this, you're supposed to do that. In case you see this, these nurses will tell this mother everything, but they will not tell them that in case the baby is not passing urine, come back to the facility. So these mothers will not know whether it's a problem or it's not a problem. So by the time this newborn is taken back to the facility, that is day 4 of life. And then they find the same nurse who is not empowered. What will this nurse say? I have analyzed and I've seen different nurses in different scenarios, and I've written in my book. Nurse number 1 will tell this mother, you know what? You're just a first-time mother. Just go back home. Yeah, you're just anxious. Just go back home. Nurse number 2 can either do something wrong, which is giving something we call pre-referral medication. They have seen the baby is having a fever. So the first thing that comes to their mind is an antibiotic. And the closest antibiotic in every dispensary is actually gentamicin, which is a drug that is actually poison to an already compromised kidney, because once the newborn is not passing urine, we are already speaking about kidney failure at this point. So this nurse injects gentamicin, and then now they send the baby to the next referral facility. And when the baby is received to that referral facility, they find a different set of a clinician. This clinician, if they have a knowledge about kidney health, they can say, 1, we need to draw samples to check whether the baby has a kidney involvement. And 2, we cannot continue giving this gentamicin. It is a wrong drug for the kidneys. And then they stop it at that. And even sometimes they escalate the referral to getting to the tertiary hospital, which is where Tabitha works, which is the only government facility in Kenya that has the capacity to take care of such a newborn. Then you will realize that the clinicians you're having on the ground, they are actually not aware that we have something called peritoneal dialysis, which is the dialysis for the newborns. I interact with frontliners every day. And when I talk to them about peritoneal dialysis, they are like, so what is that? We thought dialysis is the only dialysis with blood and machines and all over. So you mean there is another dialysis for newborn babies? Yet these are the people who are expected to take action at the level 3s and at the level 4 facilities. So let's go back to that mother who was sent back home because they are seen to be a first-time mother who don't know how to breastfeed, but they were kicked back to the village. What happens to this mother? They'll go back to the village. They'll try whatever maybe they can do. If a friend advises them that, you know what, in our culture, we usually say that if a baby is not breastfeeding, it means that their small tongue is actually is long. It is causing them not to breastfeed well. So we need to take the baby to an old granny somewhere to have it cut so that the baby can breastfeed. Some cultures, like where I'm working around, their culture, they insist on gum cutting, where the baby, they just say the baby has false tooth. That's why they cannot attach to the breast. So it needs to be scrapped off. And then what happens? The baby gets infections and the baby cannot even breastfeed for the next, I don't know how many days. And things get worse. And of course, we lose that baby at the community level. And that baby is dead and buried. And then this mother is blessed enough again to conceive and to get another pregnancy. And if they have the same issue of delayed lactation, because the midwife where this mother attends clinic is not empowered enough to prepare mothers for breastfeeding long before the baby is born, so the mother will get the same cycle repeating itself again. I'm sure the audience have heard of mothers who are known to lose their newborns within the first week of life. If you investigate further, you could get a linkage relating to what I'm speaking today, because midwives are supposed to treat mothers on how to prepare for breastfeeding. Mentally, they need to know that I am expecting a baby. So in my brain, I know that in 9 months, I'm going to hold a baby and I'm the only mother to the baby. Psychological preparation. Number 2, they are supposed to be taught the correct nutrition. And number 3, they are supposed to be taught on how to physically prepare for the breast, so that once the baby is here, we don't waste the first 24 hours. So Moses, that's just one illustration of just the newborn. I've not touched on how the frontline comes in for the mother, for the fathers, and for everyone. So it's a whole series maybe we could do. Yeah.
Let me interrupt for a moment, because our time, we're already over like a half an hour of our time. But so how do those frontline workers, not speaking from a mother with a baby perspective, but for someone that got kidney disease, how do those frontline healthcare workers play in identifying kidney disease early before it reaches the stages of dialysis?
Okay. It depends on where the patient is. It depends on the facility that the patient is at, because our system, our healthcare system, we start all the way from level 1, which is the community, level 2, 3, 4, going up to the tertiary hospitals. And we can have sometimes even the level 4 facilities having no capacity to do a kidney function test. So the patient can be managed for infections, query, whatever. But kidney like not being at bay. However, in a good world or in a perfect world, and also with some of our colleagues, frontliners who have really stepped up, they can be able to pick some of the symptoms, such as the swelling of the body and the face, and issues to do with urine changes, whereby a patient is not able to pass in. The urine input and output balance is not is not telling per se. Also, the vital signs, sometimes they can hint into the kidney, because as we were talking about the functions of the kidney, the kidney has a role in your blood pressure control. So if the kidney fails, what is the result? Your blood pressure will misbehave. So even the high blood pressure is also a sign, like the high blood pressure that is beyond control, it is also a sign that can be picked. And the swelling, especially of the lower limbs, is also another telltale symptom of kidney disease. So yeah, we are able to have frontline workers who are able to pick that and in time. Otherwise, misdiagnosis is still very common. People could just be only thinking about the low albumin and overlooking the kidney function in itself.
So, Ms.
And
Rose,
also, yeah.
I'm sorry to interrupt. So basically what you're saying is there's a lot of frontline workers that are not actually prepared to detect or identify kidney disease early before it reaches the stages of dialysis.
Yeah. Because us in the nephrology space, before maybe more advocacy or like more kidney health advocates from the nephrology space have started coming up, we could only talk about kidney health to our colleagues only when it's World Kidney Day. Only when it's World Kidney Day, that's when nephrology nurses and nephrologists would just post something to do with the symptoms of the kidney on social media. That's when you would be seen around talking and walking and having events on kidney health. Probably that is the only opportunity we have been having to reach out to our frontline healthcare professionals. Mm-hmm. But with more of the Renal Ready campaign and more champions and more nephrologists even in Kenya getting into the space of advocacy, the likes of Dr. Soki, Dr. Hussein Baga, and more of others, then we are able to have a wider reach for the frontline to support them, because they cannot support us from a place of ignorance. They need to be empowered.
Mm-hmm. So,
yeah.
So my next question, Brother Moses, are you finished?
Yeah, I'm done.
Okay. So, because like I said, we're over 30 minutes, but that's okay. You mentioned Dr. Soki and other professionals and yourself working in the community. So from your perspective, what are some, you could give us maybe one or two, what are some common misconceptions or fears in the community still have about dialysis? What are some maybe one or two common misconceptions or fears people in the community that you hear about still have when it comes to dialysis?
Okay, one, they have misconceptions about the dialysis procedure, and they also have misconceptions about the kidney disease in itself. Because one, with the symptoms of kidney disease, I usually tell my audiences that it has symptoms from the head all the way to the small toe. So if you knew someone today and then 5 years in dialysis, or even when they just maybe the ones who come in with the acute symptoms, probably last month they were looking all the same, and then in 2 months their body is swollen. Even if it's a man, their pot belly is so big, like as if it's a 9-month pregnancy. Maybe their skin tone, they are more dark. Some others, they become very emaciated. They become very slim. So this is Africa. And I live at the heart of communities where witchcraft is still blamed as a cause of many things. People blame it on curses, taboos. Maybe it's a ritual this or a ritual this that you did not do. that is what maybe caused you to doing that. So you can find even a patient skipping dialysis so that they can go back to their village to try and sort out with the village elders whatever rituals they think needs to be done, so that they are let off the hook of dialysis. And of course, in that duration, the patient is of course deteriorating in as much as they are busy trying to look or to blame on other issues rather than embracing this scientific research that has been done and the diagnosis and just taking it forward. So issues to do with blaming it on cultural rights, taboos, and curses, it is very common, and even spiritual. Just saying that you did not offer this offering, you didn't do this sacrifice in church. That's why your pastor has probably given you this curse, and yeah, here you are. And also, they also tend to feel like your lifespan is like you are going to die the next minute. So even if like now we are on season of elections is loading, and of course some of the kidney warriors maybe want to take part in some of these elective positions, people can say, you know what, this one will not even make it 3 years into the election. So why can't we elect someone with a sustainable leader? This one, I usually hear they go and have their blood washed at the hospital. So all their blood is taken out of their body. So how can we have such a leader representing us? So there is a lot of stigma because of the ignorance that is out there. Because even the televisions, they do not show that part of kidney failure. They talk about kidney disease on the news, but it is less emphasis on what actually happens inside the dialysis unit. So I'm hoping that someday we can have a series of shows that is taking people through what actually dialysis is, so that these patients can be embraced back in the society.
Wow. Yeah.
And maybe Brother Steve, to add, I once had a patient who was saying that the wife was saying that if they have conjugal rights, he's going to transmit the disease to the wife. It's good for the community to know that kidney disease is not transmitted and it's not like a sexually transmitted disease. So do not deny your partner the conjugal right, thinking that it is transmittable. Yeah, just correct the myth. Yeah.
Okay.
Wow.
Tab, I think the next question is on you.
Okay, thank you. Nurse Rose, how important is patient education in helping? How important is patient education in helping the clients manage their treatment successfully? Patient education. Yeah. How important is it?
Yes. It is very, very important. And just as you had alluded earlier, that of course we are supposed to wait on when the patient is stable enough to be able to take in what you are actually teaching them. You cannot teach a patient with high blood sugar that they could just collapse the next minute. You need first to ensure that the patient is stable, is out of danger, and now you are able to give them information gradually as they can be able to handle, as you evaluate how best they are implementing it, and also as you customize and modify the same information to different patients given their age, like customized health education. You cannot give this health information to Moses, and also you give the same to an 80-year-old patient. You have to kind of tailor these health talks to what really applies to the particular patient, and that really helps them in terms of their compliance. You find that even as they do their routine kidney function test, they are improving, and you see that speaks into how they present generally. If their kidney function test is good, then they are stable and they can be able to carry on with their activities of daily living. So if they are not stable, then that means they will keep getting admitted and slowing down their lives here and there. So yeah, patient education is key, and that's why we are advocating for more numbers of nephrology nurses in the unit, and also having a dedicated nurse in each dialysis unit who is actually addressing the issue of patient education and psychosocial debriefment for the patient and the families.
Thank you so
Wow.
much, Rose.
Wow.
Yeah, the way you say it, it's very, very important, health education, because of even adherence, infection prevention, management of anemia, getting back to work, coping with life, and getting even back to work, managing the anger, all that. So much to patients' education. Yes, Moses, go ahead.
Thank you so much, Tabitha. What challenges, Rose, this is your query. Yes. What challenges do nurses themselves face in providing quality dialysis care, and how can those challenges be addressed?
Wow, amazing. Thank you for that question. So I would not I've overemphasized on issues to do with the staffing, the ratios, of course. Dialysis nurses are getting burnout, serious burnout. I'm talking about serious burnout, because when the machines fail, that means the delays in the unit will affect the staffing ratios. If the nurse was supposed to leave at 4 p.m., they might even find themselves in the unit at 10 p.m. And the following day, they are supposed to be at work by 6 a.m. So that is a challenge in itself. Number two, and I just say there are those system related challenges, like those ones, and also there are some other challenges that are really, really personal, like the loss of patients in the patients who are in our dialysis circle. Let me say that I still grieve over patients I lost over 10 years ago, because why? We had such a close-knit relationship with them and their caregivers. We could do like vision board together. We could just see like we are talking about this patient. We are seeing their life in the next 5 years. We are talking already like, you will already have gotten a transplant. And of course, you will already be having your first baby. And of course, and then all of a sudden life is cut short by death. That sometimes in Kenya, people say, manas ni wabaya, manas ni heartless. That means like nurses are very heartless people, because probably we give some painful injections. But let me tell you, from within ourselves, I think we are the most fragile. We are the most fragile people, because we see lives lost more than any other profession. Because even the nephrologists themselves, sometimes they are not there in the unit with us as we are building this relationship with our patients gradually. They only see the doctor for 5 minutes, but they are with us for 4 hours, 2 times in a week, 8 sessions in a month. We are family. The dialysis patient only knows of this nurse. So when we lose those patients, we grieve, we mourn those patients. So I usually encourage, even in our project that's about the kidney health safaris, where we are going around different counties, we have a specific package that is actually targeting the nephrology nurses, debriefing them over these losses or for these patients, because like in my workplace, we have a special room for us nurses, for where we go and grieve, where we go and mourn. Because when you lose the baby, you don't want to cry in front of the relatives. You don't want to carry that pain to your children back at home. So you are allowed to go into that room. You cry all you want, and you have your colleagues helping you to go through that pain. So it is much. Some are system related, others are just within.
Wow. Back to you, Steve. Thank you so much, Rose.
Hey, Rose. So let me understand this. So now you go back and forth between dialysis and working in newborn.
Nope.
You work in newborn?
Yes, I work in newborn, and then when I'm off duty, I'm either seated in my house, writing, thinking, strategizing, planning, doing virtual meetings with my teams, doing interviews like the way we are doing now, going out in the community. Yeah, I don't work in the dialysis unit. I work in a hospital that has a dialysis unit, but I don't usually step into that unit, because I usually feel like if I was to move from the newborn unit and work full time in the dialysis unit, I will lose track. I will lose focus on. I started my career from working as an on-job trained dialysis nurse in one of the busiest hospitals in my country, especially in terms of dialysis services. It's called the Nairobi West Hospital. It has a very high capacity for dialyzing patients. That is where I started working as a general nurse in the wards. And then I got curious and I just wanted to go in and see what's in the dialysis unit, what happens there. So that's how I got absorbed into that renal unit. And I really worked for 2 years, and we could do 60 sessions in 24 hours. So talking of being hands-on in terms of dialysis skill, I got hands-on. At the same time, I got now to see these stories of my patients, trying to interview almost all patients to see how did they get to that space. So when I realized that almost all cases were preventable, either by frontline healthcare worker empowerment or through educating the masses, then that gave me my mission. So I said, yes, I'll continue working, but when I'm off duty, I'll be trying to build a blueprint on kidney disease prevention, that for which any nurse anywhere can be able to replicate and do the same for the community, because it felt like God was placing that burden so deep in me. Much as I've tried to run away from this so many times, God always has a way to bringing me back, to swing back into action until I can replicate myself in many other people, and I can just sit back and enjoy my day offs and take vacations here and there.
So you mentioned prevention. So my next question, many people ask whether dialysis is the only option once kidney disease gets severe. Excuse me. Can you briefly share with us what should patients understand about prevention and early care?
That's my question? Okay.
Yes.
Okay, infection prevention for dialysis patients. Number one, of course, it starts at the health facility where they are undertaking dialysis. Of course, all standards of operations should be followed upon the cleaning and the dressing of the dialysis access. And number two, the patient is supposed to be taught.
Excuse me, I think you may have misunderstood what I said. What I was saying was many people ask whether dialysis is the only option once kidney disease gets severe? What should patients understand about prevention and early care?
Okay. So this takes me back to what I had alluded earlier. There are levels of kidney disease prevention. Number one, we have the primary prevention, whereby we are looking at these communities out here, these people out here who are not having any risk factors of kidney disease. How can we make sure that they don't get these risk factors? And these risk factors include obesity, like high blood pressure, diabetes. How do we make sure people don't get to be obese? How do we make sure that people don't get high blood pressure? How do we make sure that they don't get, diabetes? So these are the times we talk about exercise, physical activity, the right choice of diet, checkups here and there. That is primary prevention. Number two, we have secondary level prevention. This is where we already have diabetes on board, we already have high blood pressure on board, we are already obese. So what do we do now so that now we don't move to the next, to getting to the kidney disease? So these are people we need to talk to them about the complications they are likely to get, starting with kidney disease as one of the complications, and discussing how to prevent each and every complication. If we are talking, we want to prevent stroke in a high blood pressure patient, we take them through that so that they can understand. So now the gap becomes when the frontline healthcare worker who is seeing this patient with diabetes, they don't know exactly what they are supposed to tell this patient with regards to the kidney disease complication. They know how to teach them about the eye complications. They know how to teach them about the strokes. They know how to teach them against the hypertensive crisis and the hypoglycemia and the low blood sugar, the whatever, but they don't know how to teach them specific information that is safeguarding them from the actual kidney disease complication. Yeah, so they are supposed to be taught at that level of secondary prevention. Then now the tertiary prevention is what I was talking about, whereby already kidney disease is here. But what are we going to do to ensure that this kidney patient is not getting admitted every other time? They're not having the low blood levels. They're not having the bone complications. They're able to keep in school, at work. They're able to do their dialysis and balance their life. They're not having depression. Yeah, so it's in different levels, and different levels come with different interventions.
Okay. All right, Tabitha, it's on you.
Thank you so much, Rose, for what you are doing. I remember there's a time you were telling me about the menstrual hygiene and kidney disease, where you are teaching the young girls.
Yeah.
Thank you, and congratulations, you're doing a good job. So, what message would you give to a family supporting a loved one on dialysis, especially if they are struggling emotionally and financially? The message.
I am smiling because wow. Okay. I am smiling because we've come a long way with Tabitha. I was once that patient. I was once that caregiver who needed that advice because I had close relatives who actually, one was in dialysis and also another was almost getting to that stage. So again, maybe I just got carried away. I just got carried away by that question because it just brought in some memories, And just again, it just felt like, okay, now I need to share. So you said the question was what I'm supposed to share with patients on financial what?
Relative.
Please come back again.
Relative. What message
Pardon?
would you give to a family? What message would you give to a family of a loved one who is on dialysis, especially if they're struggling financially or emotionally?
Okay, thank
Financially.
you for that question. Yes. So, number one, this psychosocial counseling training that I'm undertaking now, I'm learning things. I've been doing them, but I've actually not been. I was not able to put names to what I was doing. We are learning about an intervention that is called linking. So, linking, LINK. That means that if a patient's family is struggling with financial issues, I stand at a place where I can be able to link this family to different avenues so that they can be able to receive help. One, if they are in a hospital setup, I could link them to the hospital administration through the social worker, so that maybe their bills can be waived, they can get discounts here and there. Maybe I could link them to the politician who is in their area, who can be able actually to chip in to some extent. I can be able to introduce them to certain members of the society, like the clergy, who can give them platform to be in their church, maybe to share their story and get their a bit of financial support. So linkage. Also, I can even link them to the media houses through my networks there, so that they can be able to have access to share their stories and get some funds to coming in to offset. And also now the emotional, how I'm supposed to deal with the emotional aspect. So I'm learning the principles by the WHO that actually guides the counseling, like how I'm supposed to look in and see how they have been able to take in that information, because different families will handle the same situation differently. I think it will be a story for another day, but just to hint or to just give an example, coincidentally, my own mother suffered diabetes for 20 years before her demise. And also coincidentally, my father-in-law also suffered diabetes for 20 years before getting into kidney failure and finally demise. The difference between my family and my husband's family was that for my husband's dad, he had already started talking to the family at a very early age, just telling them, do you know that, yes, I'm diabetic? And one day I could just wake up and my eyes cannot be able to see because of this diabetes. Do you know that even one day I can just wake up and my kidneys are not working? So what will you do at that point? Those are things that he used to tell his children very long time ago, even as they were growing up. So even when this thing came, they could flash back and remember that their dad had actually prepared them. As opposed to our family, where my mom had the same medical history, but in our family, the mention of the word diabetes was forbidden. We were not supposed to talk about my mother's medical condition. We were just supposed to focus on our education and know that we are children in that house, and we are not supposed to contribute to any decisions that entail my mom's medical condition. That was us growing up, and we never got to be oriented on this. So even when I went to nursing school, when I was learning some things about diabetes, when I come back home and start talking the same to my mother, she would really dismiss me. She would say that family, our house is not meant to be having diseases like the topic on the table. We are not supposed to discuss diseases. My condition is just privately mine. It's not something that you're supposed to. I remember she used to keep her insulin in her bedroom, and she would just hide and just get her jabs. And even when she used to go for clinic, she would tell us, in case anyone asks where I am, just tell them I went to town and I'll be back by evening. And he never wanted even anyone to find out whether she's diabetic or not. So when kidney failure came knocking, and we had to get involved, it really hit us so bad, as opposed to the other family. So I'm talking about this to say that you'll start counseling from different points based on how prepared was this family, so that now you can tailor your support accordingly. Yeah.
Thank you so much, Nasrot, for what you've really shared. It's really going to bring a lot of insight in the life of very many people, and you've really helped us understand so much. Maybe even as we are concluding, maybe you can tell us about your book.
My book? Okay, so my book is at the publisher's desk as we speak. We are gonna launch it before the end of this month on Amazon. So hopefully in the upcoming Kenya Renal conference, we'll have more time to talk about it. I had done like a draft of the same book, and I had around 50 nurses who were able to read it and give me some input and feedback. And from that, now I was able to embark on a journey of writing an expanded version for the same book with a whole brand new concept, and it has reviewers from all over the world who have been able to selected reviewers from all over the world. I've had reviewers from different parts of the continent who have reviewed the book and shared their feedback. And of course, now it's at the publisher's desk. That's my first book. Then I'm also working on another 2 books. The second book, it's called Every Woman's Kidneys, because I really like to customize my talk based on who am I talking to at what particular time. So I realized that women have very pertinent issues and very broad issues that revolve around them. So I'm writing a book specifically that's addressing the women and the kidney health, inclusive of what Tabitha is talking about: menstruation and kidney health, the UTIs, childbirth and pregnancy and all that. So it's coming up. Then also the third book is a book for all. It's called The Kidney Health Conversation, because I'm this person who would go and start a kidney health conversation wherever I go. I even go to the local parliament, the county assembly, and start talking to policymakers about kidney health. I walk into an office in Nairobi and I just tell them, hey, did you know that this and this, I just go to a shelter where we have the motorcycle riders in Kenya, and I just wear a cape and I just look and talk like them and get to their level and just vibe around, and then they just get to understand kidney disease at their level. So it's called The Kidney Health Conversation, where regardless of who you are, regardless of your level of education, we can come to a space where you and I can get to understand. We can get to start a conversation. And all these books they are just like teaching aids, because I see myself being more of out there, talking more, and then just leaving them with something to hold on, to read on, and also the books can go far, even to places maybe I'll never have the chances to step foot to.
Thank you so much, Nasros, and we just love what you are doing. Keep doing it. I love your courage. I've never stepped in the parliament, but thank you so much. You've been there and you're doing something great. I hand it over back to Brother Steve.
Yes, Rose, I'm going to just ask you one more question because we're way over our time. Just one final closing question is, what is one powerful message you would like every Kenyan to hear about protecting kidney health before dialysis becomes necessary? One brief.
Okay, my slogan, as I said, you will never understand the value of something until you lose it. So it is until you know what your kidney does for you. If only you knew what your kidneys does for you, probably you would step up on your daily habits. And one conversation starter that I like with my almost all audiences is that, did you know that once you get kidney disease, you will never be having an opportunity to take water ever again in your life? So that becomes like a light bulb moment, and suddenly everyone is interested to know, like, how can someone survive for years without taking water per se? So now that's when now you start the conversation. So prevention is better than cure. Take care of your kidneys. And for the people out there who have platforms where people can share this information, just have us there so that we can reach as many people, because we cannot finish all this in one sitting. We need more of kidney health conversations.
Now, I definitely agree with you on that. I definitely agree with you that we definitely need more kidney disease conversations, more people with this type of platform to get that information out there. So I just want to thank you so much, well, not you per se, but everyone for staying with us on Kidney Hub East Africa. Brother Moses, do you have one last thing you want to share before we close the show?
Oh, yes. I just want to thank everybody for making it up and ensuring this show becomes a success. And my special request is to Nurse Rose that we are not going to take this for granted. We are so grateful. So thank you very much for showing up, and we hope of having you anytime once again. Thank you.
Yes, and Moses is experiencing some power grid experiences. That's why you see him in the dark there. Tabitha, any last parting words from you?
Thank you so much, Nasros. I really appreciate what you are doing. I love the energy and even the potential that you have. And I like how you are unique in your own style in managing the kidney disease. Thank you so much. Yeah, thank you for the value you're adding even in this conversation. Thank you.
Absolutely. Nurse Rose, where can people, you said you're an author?
Yes.
Yes, where can people find your books?
My book will be soon launching on Amazon.
Okay, is it on Amazon now?
So Yeah, before the end of this month, it shall be already launched. And that book that's coming out fast is specifically for healthcare professionals. It is not for the general public consumption. It's called the Renal Ready Workforce. So it is specifically for healthcare professionals. So that's why I'm looking out to do book tours, book campaign, because I'll be targeting hospitals and where healthcare professionals are found, like in universities and campus colleges. Yeah, and also for the online community, it will be clear that that book specifically is for the medics. Then we shall have the one for the general public, which is the kidney health conversation, which now will take up hands-on fully after this one is launched. So we'll have it out probably by the end of the year or early next year. Yeah, in that sequence. But the campaign continues, the advocacy continues, the screening continues, and the kidney health tours continue.
Got you. Wow, it seems like you got a lot going on. But a special thank you to our guest, Nurse Rose, and to my co-host, Moses Kennedy, the Kennedy Ambassador, and renal nurse specialist, Tabitha Matekwa, for sharing such valuable insights on dialysis in Kenya, challenges, gaps, and solutions from a nurse's perspective. Today's discussion reminded us of the importance of access, affordability, quality of care, and early detection and protecting kidney health. We hope this conversation has helped create more awareness and inspired action toward better kidney care for all. To our listeners, remember, prevention is powerful. Early screening saves lives, and informed communities are healthy communities. Thank you so much for staying with us on Kidney Hub East Africa. Special thank you again to our guest, Nurse Rose, again to my co-host, Moses Kennedy, the Kidney Ambassador, renal nurse specialist, Tabitha Matekwa, for sharing this valuable information. We see y'all soon. Take care. And thank you, Nurse Rose, Brother Moses, and Tabitha, again, for this powerful conversation. And we see everyone next week, same time, same channel. So thank you, everyone. Goodbye.
Mm-hmm.